Good afternoon and welcome to today's program titled Understanding and Treating Post-Traumatic Stress in Service Members and First Responders. I'm Tom Valentino, Senior Editor at the Institute for the Advancement of Behavioral Healthcare. Today's program is sponsored by Sierra Tucson. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few details we'd like to go over. To submit a question for our presenter, please use the Q&A area below the slides at any time. You do not have to wait until the end of the program to ask a question. To troubleshoot technical issues, please click the Test Your Connection button below the video window to chat with support. To download a copy of the presentation, please click the link in the Resources tab to the right of your slides. Special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. At the end, do not leave the web page. The site will automatically redirect you to a survey, and this must be completed in order to generate your CE certificate. For those watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. Please note CE credit is not available for the archived webinar. It's only available for the live event on May 9th, 2018. Finally, for those of you who tweet, please tweet along with us using the hashtag IABHCLiveWebinar. At this time, it's my pleasure to introduce our speaker, Dr. Aaron Wilson, Chief Medical Officer at Sierra Tucson. Dr. Wilson received his medical degree from Tulane University School of Medicine. He completed his residency in psychiatry and served as Chief Resident at Tulane's Department of Psychiatry and Behavioral Sciences. Prior to joining Sierra Tucson, he served as Chief Medical Officer of Valley Hospital in Phoenix, Arizona. He also served as Medical Director of the Freedom Care Unit, which focuses on the specific mental health needs of military service members and first responders. Thank you, Dr. Wilson, for taking the time to speak with us today. And with that, the audience is yours.
Thank you, Tom, and good afternoon, everyone. I just wanted to briefly say that really my interest in working with trauma and first responders, for the past about 6 or 7 years, that's been the patient population that I've really specialized in. Prior to that, growing up in a household with a combat veteran as a father, obviously it strongly shaped the direction that I ended up going with my career, obviously in psychiatry and trying to figure out some of the inner workings of some of the PTSD and things that he had struggled with. During my medical training, I actually was at Tulane University in New Orleans at the time that Hurricane Katrina hit, and so got to see firsthand and really had a lot of experience working with people after the acute stress response and a lot of the first responders that were there to help with that response. So it's basically shaped the direction my career has gone. Since I've been at Sierra Tucson, we've really been interested in building a first responder program. And I think, before you can really build that infrastructure for a first responder program, you have to understand the neurobiology of trauma. You have to understand the unique characteristics and some of the subtleties of working with, active duty service members, veterans, and first responders, because it is a unique patient population, and there's not a lot of room for error in working with that population. So I'd like to move on and speak about these topics with you. So I have nothing to disclose at this time. All right, so the objectives of this talk will be to define the neuroanatomy associated with the trauma response. We're also going to explain the mechanisms of medications we commonly use to treat traumatic stress, describe the therapeutic modalities currently being used to treat traumatic stress, and also define resilience and describe the difference between what we are born with and what we can learn. So just wanted to briefly talk about the scale of trauma, which I know we are all familiar with. The depressive symptoms are nearly double that of the general population with first responders. The rate of suicide for law enforcement officers is approximately 18 per 100,000. Over the past 4 years, an average of 127 firefighters and EMS have completed suicide each year, and an estimated 60% of those are not reported. And then the rate of alcohol use reported to be less than or equal to general population. What I wanted to speak to on this is it's very difficult to get accurate numbers as far as suicides, mental health diagnoses, and substance abuse. There's a lot of different confounding factors in that. There's a lot of things such as underreporting, possible cover-ups. There's a lot of effort that goes into protecting the first responders' reputation, protecting the family emotionally. So these are all things that kind of factor in. And really, there's a lot of course, we'll talk later in this talk about stigma and some of the other things that contribute to maybe some underreporting on these numbers. But it's definitely come into the forefront lately. More on the scale of trauma, 60% of all men will experience at least one trauma in their life, 4% will develop PTSD, 50% of all women will experience at least one trauma, 10% will go on to develop PTSD. As far as veterans are concerned, looking at the Vietnam era, there were 15.2% of Vietnam veterans were diagnosed, but that's actually jumped up and over a lifetime has gone up to 30% lifetime prevalence. Estimated 12.1% of Gulf War veterans and an estimated 13.8% of the OIF/OEF veterans have been diagnosed with PTSD. So to move on to a brief review of neuroanatomy, and I promise we'll try to keep this brief to keep everyone's attention. We're going forwards. So to talk about neuroanatomy, the key concepts and some of the key players and neuroanatomical structures I'd like to talk about very briefly, and the flow of that information. So all of our sensory information obviously comes from our eyes, nose, ears, skin, and it is all processed through the thalamus. The thalamus is basically where your brain decides, or basically decides this is what is happening to me. This information is then passed on to the amygdala with lightning speed, where the emotional significance of this information is determined. If there's a threat that is detected at that point, the amygdala will activate the autonomic nervous system, specifically the sympathetic or the fight or flight response that we're all familiar with. This is triggered by powerful stress hormones, namely adrenaline and cortisol, which we'll talk more about as this talk progresses. There's also a slower path, or the high road, which if we're able to engage the prefrontal cortex, this is where you have a lot more time to think and process what's happening. So once that information gets to the prefrontal cortex, you can make a conscious, much more refined response as opposed to the automatic fight or flight response. If you go down the stress response pathway, you end up with the HPA axis, which people hear so much about, which is the hypothalamus, pituitary, and the adrenal glands. This, of course, is a pathway that's also responsible for other neurotransmitters such as oxytocin, thyroid hormone, prolactin, and the sex hormones. Specifically talking about the autonomic nervous system, the sympathetic path, or the fight or flight, sorry for delay. Fight or flight is responsible, what the physiologic response would be to dilate the pupils, increase the blood pressure and the heart rate, increase arousal, decrease digestion, and suppress the immune system. If you move along the other pathway, which is the parasympathetic, you're looking at rest and digest. It does basically the opposite. A lot of people look at the sympathetic pathway as the accelerator, and the parasympathetic would be the brakes. Apologize for the dramatic pause there. So now that we have some of the key players and the neuroanatomy underway, I wanted to talk about what happens as far as trauma and the trauma response. So you would look, the first thing that would happen, of course, is the thalamus shuts down. You essentially lose the autobiographical memory. The trauma is remembered as isolated sensory imprints. Oftentimes it's not remembered as a story, but bits and pieces. Key sights and sounds that are fragmented. You also have impaired attention and concentration. You cannot filter their sensory inputs. You basically can't tell what's important and what's not, so it's information overload. The amygdala goes into overdrive. Again, the amygdala is essentially looked at as the smoke detector for the nervous system, so it can't determine what's a threat and what isn't, so oftentimes it will think that everything is a threat, and that's where a lot of the hyperarousal and hypervigilance comes from. The prefrontal cortex, again, that's how you make a conscious decision, is offline. You get stuck in that fight or flight mode, so oftentimes you're not able to. You go into these pre-programmed stress responses as opposed to having a conscious awareness of the events. You lose a sense of time and become trapped in that moment. And then the autonomic nervous system, you get stuck in that fight or flight response. So again, you'll have the heart rate, the blood pressure, pupil dilated, the fuel availability, and clotting. You'll have a decreased immune response, digestion, and relational ability because, again, when you're in fight or flight, that's not what's important to you. So you can imagine the chronic effects of that on your body. So really, I want to look at how these changes in brain function really manifest themselves. So from a mental health standpoint, this is where your criteria for PTSD and post-traumatic stress in general come from. So you look at reliving the event or re-experiencing. These are the symptom clusters if you look at PTSD as a diagnosis. Reliving the event, such as nightmares, flashbacks, and triggers. You also will have avoidance or avoiding situations that remind you of the event. You'll start to have negative feelings or negative changes in your beliefs and feelings, as well as feeling keyed up or hyperarousal. So I want to talk a little bit about what it's actually like to work with patients, and I appreciate you bearing with the neuroanatomy. Typically when I work with first responders, active duty military, and veterans, the first question they ask me after they tell me their story would be, so am I crazy or what, doc? That's probably the most common question I get. So there's a lot to that, and of course it's a complicated question. Of course I reassure them that they're not crazy, and a lot of this is a normal response to a significant stressor. But I do want to talk a little bit about some of the implications of diagnoses. So for service members, first responders, there's a lot of career implications, and so there's issues establishing trust and rapport, but also it's really about what are the implications of this on my career. Am I going to be able to stay on the line of duty? Am I going to be deployable? Am I going to be good to the mission for military? And so it's not just what is my diagnosis, it's how does that affect my career, my ability to provide for my family. So a couple points about whether or not we diagnose PTSD, and again the D, we've spent a lot of time on the disorder word, we call it the D word. Trying to avoid that, when you're working with first responders, I think is important, just because the word D in disorder has a lot of negative and seemingly permanent connotations for people, and oftentimes in the biz, if you will, we'll look at it more as a post-traumatic stress injury, just because an injury by definition is something you could typically heal from, and that's what we want to imply with our service members and first responders. Just as far as clarification between a couple different things, I get a lot of questions about complex PTSD versus cumulative stress and trauma. Don't want to spend too much time on that, but I will say that complex PTSD historically is looked at as chronic, recurring, or constant trauma, a lot of times looked at as childhood, where you're in an abusive, neglectful dynamic with a caregiver. More so with first responders or with military, you would think of things as concentration camps, prisoner of war. Again, it's the implication of complex PTSD, though, is that you're kind of helpless in that situation. You're not able to escape, and you don't have that sense of agency. Whereas, of course, if you're, a first responder or an active duty service member, it's a different situation altogether. Again, with kind of the stigma of diagnoses and some of the implications, there have been different attempts, and of course, there's different task forces looking at different diagnoses for them. One of the other ones that has come up through the police department would be an emergency responders exhaustion syndrome. Very, very similar symptom profile, but it may speak a little bit more to some of the symptoms that you see kind of on the burnout spectrum, which would be depression, isolation, exhaustion, anger, and maladaptive coping. So we are, of course, looking at ways to change the diagnoses around and make sure it really fits to this particular patient population. So I think it's also important to remember that first responders and the therapy staff and the therapists that are taking care of them come from different worlds. Just if you look at the profile of first responders, and again, some of this is stereotypical, but a lot of it is in the research. So typically it would be an action-oriented individual, very decisive, very assertive, live in a world of probabilities based on past experiences, and really value tradition, conformity, structure, teamwork, and predictability. In sharp contrast to therapists who encourage reflection before action, they're contemplative, we live in a world of possibilities, and really value individuality, spontaneity, and emotional expression. So I think it's important for us to remember that, of course, we're coming from different worlds. The characteristics of first responders are the things that keep them safe. They live in this world of probabilities. Really, they view people who can't make decisions as wishy-washy and also dangerous to work with. And so it's important that we know these are barriers or potential barriers to treatment and that we identify them. Really, I mean, it's as simple as looking at, if you work on a unit with first responders, it's, if the therapists come in and they put their MSNBC on the news, and then you have the first responders want to come in and watch, and typically they might want to watch a different brand of news. There's liberal and conservative. There's just differences across the board, and so it's really how do we find that common ground and really relate to each other and really make them feel safe and trust in that dynamic. So speaking of barriers to treatment, couple key points here. Pride. So you will never meet a more prideful group of people. The pride, of course, comes with a price and an expectation. It's got a little bit of a perfectionist undertone, if you will. A lot of times people will view needing help as a perceived sign of weakness. Won't be a good teammate if I'm broken. I don't want to embarrass my family. There's a lot of these things that play in. So identifying those and finding workarounds are really important. The other, of course, the S word, if you will, or stigma. Stigma, of course, would be that therapy is a bunch of people sitting around holding hands and singing Kumbaya, and I hear that all the time. I've never actually done that, but it's important to identify that as the perception, and really that seeking help is a sign of weakness again. So there's also, as far as confidentiality and stigma, there's a quote of a patient I once had who basically said that if you want to spread the word, you just tell a secret to a coworker and it'll be out on the street before you are. And so I think really the word travels fast, and people are oftentimes afraid to share that with their coworkers. So, and the last key concept I wanted to talk a little bit about is just fear. So not fear in the traditional sense of the word. It's almost a little bit ironic that the only time first responders and service members are willing to talk about fear would be the fear in regard to seeking help. And so there is a fear in reaching out for help, a fear of suspension, possible job loss, a medical board process. And really, as far as treatment goes, there's also a fear of losing your edge, a fear that if you get on medications and you do therapy, that you'll have to let your guard down and that you'll lose your edge in the field. And I think really being aware of that and talking about it with your patients is important. So shifting gears a little bit, I want to talk about medications. This is a real hot topic here. As we develop a program at Sierra Tucson, we're being very mindful of this. And so 2017, the VA and Department of Defense guidelines for PTSD treatment actually recommended therapy as the first line over pharmacotherapy. And for any of you that work with the VA or for the VA, that's really saying something. I think historically the VA has been associated with a lot of prescribing and trying to, pharmacologically treat a lot of disorders. So I think that it's a very important and significant statement for them to say that. So I do want to talk a little bit about some of the medications that are actually approved, and there's some evidence for with PTSD. As far as antidepressants go, this is actually nothing new, but there are the four that have their strong evidence in support of their prescribing at this point, which would be sertraline or Zoloft, paroxetine or Paxil, fluoxetine or Prozac, and venlafaxine or Effexor. Weak evidence would be in support of another category, which would have nifazodone in it, imipramine, and phenelzine. There's actually weak evidence against citalopram or Celexa and amitriptyline or Elavil. Now, it's important for me to say that this is by no means that if you have a patient who's responding very well to any of these medications that you have to take them off and switch just because of the evidence here, according to the Department of Defense and the VA. It's just more of a guideline and can hopefully guide us as we move forward. As far as mood stabilizers, another somewhat controversial topic. You'll oftentimes see patients on quite a casserole of medications. As far as mood stabilizers go, Lamictal or lamotrigine has weak evidence against its use for PTSD, as well as Topamax, which originally is an anticonvulsant used for migraines as well, but some people will use it for a mood stabilizer, and there's actually weak evidence against that one as well. There is strong evidence, however, against the use of Depakote or valproic acid for PTSD, and again, you will see that out in the clinics. And then really briefly to wrap up, I wanted to talk about antipsychotics. This is, again, a controversial topic, especially for PTSD, but a lot of times people feel that they're grabbing at straws to really help with PTSD and nightmares and insomnia. So Seroquel, which is prescribed very typically for insomnia for multiple different diagnoses, there's actually weak evidence against its use for PTSD, as well as Zyprexa and the other atypicals in that class or antipsychotics. And there's a blanket statement against Risperdal, as there's strong evidence against its use for PTSD. Just a few others I wanted to mention. There's a lot of talk around benzodiazepines. Truthfully, there's strong evidence against their use for PTSD. In fact, a lot of that's due to their addictive potential and limited efficacy. So obviously there's a strong recommendation against benzodiazepines. That would be your Valiums, your Xanax, Ativan, Klonopin. Some of these other medications listed are actually, there's still ongoing clinical trials looking at some of the utility. What I will not probably get into on this talk due to time limitations would be cannabis and the cannabis derivatives, as that is a very hot topic. The other one that I wanted to briefly mention on, that's not on this list, would be gabapentin. And gabapentin has kind of taken on a life of its own and is really being prescribed across the board. It originally, it's been around for 25 years. Originally, it was used for peripheral neuropathy and neuropathic pain. It has really been used lately for pretty much everything. You will find many people on it. As we've moved forward in the opioid epidemic, there's a lot of pressure on providers and prescribers to find alternatives to opioids. And typically in that pattern, what happens is that we look for these alternatives and we possibly overuse some of them. And then what patients figure out is if they take enough of certain medications that they can actually get a high or augment the high of other things that they're taking. And so gabapentin actually recently, there's been a lot of concern in the medical community about people abusing it and its abuse potentials, which is nowhere near, of course, benzodiazepines yet, but I think if we're not careful, we will end up in a bad way. So we're looking at tighter restrictions on gabapentin, changing its schedule. The abuse rate for gabapentin went up 400% from 2006 to 2015, and I think those numbers are continuing to climb as we look for alternatives to opioids. So just something to be mindful of. And the last piece on pharmacotherapy as far as specific medications would be prazosin or prazosin, depending on where you're from. There was weak evidence against its use for global symptoms of PTSD. There was insufficient evidence as far as its use for nightmares. I think the challenge we face is there's not a lot of alternatives as far as psychopharmacology goes for nightmares, and we often use it even with this kind of inconclusive evidence at this point. So I've seen that evidence go back and forth, and we'll just continue to monitor that at this point. So really, I wanted to talk about our approach at Sierra Tucson. We're looking at how do we get away from having 22, 24, 28-year-old healthy people come into facilities and come in maybe on 1 or 2 medications and leave on 10 or 12 or a handful of, and having to have a pill minder to keep track of what meds they're taking. And really, I think that that's happening across the board, probably more so even here in the United States. And so what we're really looking at doing is adopting an approach where we collaborate with the outpatient providers to make sure that we're not reinventing the wheel when people come in for treatment. As many of you know, there's nothing more frustrating than you send a patient into a treatment center and they come back and they've completely, reinvented their medication regimen, even though you've spent years working with them. And so really getting the outpatient providers involved is important. Collaborating with our pharmacists here on campus, looking at drug-drug interactions, how do we minimize these interactions and make sure everything that they're taking makes sense and is setting them up for success. We also have naturopathic physicians that we collaborate with because there's a lot of alternatives to some of the, quote-unquote heavy-hitting medications that we might use, and getting their input, and oftentimes the belief system of your patient will line up with that. So it's nice to have that as a resource if you can. And really adopting a less is more strategy as far as prescribing goes, and minimizing polypharmacy. It gets back to, I don't want to have young patients that are taking, more medications than a 72-year-old man with a bunch of medical comorbidities. So making sure that every medication we prescribe makes sense, that they're not interacting with each other. And this is particularly important with first responders and active duty military. And the reason I say that is that every medication we prescribe has the potential to have really have limitations on their ability to perform their duties, their ability to deploy with the military. So we have to be mindful as we build our program here to make sure that we are, really less is more, prescribing exactly what they need, and working with them and their belief system on what is appropriate pharmacotherapy for them. So this next slide, talking about the Sierra Tucson model, really the goal of this slide was to see how many things we could fit onto one slide, but also to show you some of the modalities that we employ here at Sierra Tucson to really target the patient as a whole, both from a biological, psychological, social model, as well as spirituality, really incorporating all those things in and having the ability to really tailor the treatment to each patient, because the one-size-fits-all or fits-most approach hasn't really worked out very well for people. And so having people come in and have these different modalities that we can look at. And I'm going to go into a little bit of detail about some of these modalities that we use here that are specifically aimed at PTSD and trauma work. So as you can see, I don't even know if you can read all these. There's quite a few, but I do want to highlight a few. So the first one I want to look at, of course, with trauma work, a lot of people associate the eye movement desensitization, reprocessing, or EMDR. This was developed in 1987 by Francine Shapiro, basically discovered that rapid eye movements can provide dramatic relief from distress. Really, what you're looking at with EMDR and the logic behind it is that you're looking at recalling critical incidents and how this will lead to new neural connections that allow traumatic memories to be processed with normal non-traumatic memories and reintegrating those. Basically, it results in a positive cognitive and emotional experience and reduction of anxiety and other symptoms. It is important to note that chronic childhood abuse causes different mental and biological adaptations compared to discrete traumatic events. And so some of the research and the data on childhood trauma and some of the complex PTSD has different results than, say, for adults who have discrete triggers or discrete traumas, such as first responders and active duty military. They actually typically do better with EMDR. So we do plan on fully employing that with our program. Prolonged exposure is another modality that you hear a lot about, or just exposure therapies and a lot of the spin-offs. Really looking at it's a manualized treatment which consists of 8 to 15 sessions, approximately 90 minutes each. There is homework involved, which it's a tough sell for people, but it's worth it. Also some journaling, psychoeducation, and breathing exercises. Prolonged exposure is characterized by re-experiencing the traumatic event through remembering it and engaging with rather than avoiding reminders of the trauma. It's basically looking from an imaginal or mind's eye view, and then also there's some in vivo or actual exposures depending on the program that you go through. One of the other modalities that we use here at Sierra Tucson quite frequently is actually somatic experiencing, and this is, if you're familiar with the work of Dr. Peter Levine, this is his brainchild, if you will. Somatic experiencing is based on the premise that persistent maladaptive core response network, or that autonomic nervous system emotional response, is the essence of trauma, and so really going after that. So basically, when you get stuck in the fight or flight, or you get even further than that and you're in the freeze response, sometimes that energy that would go towards the fight or flight response becomes trapped in your body. If that energy is trapped and the body feels it's under threat, you get a lot of dysregulation, a lot of dissociative type features, and it's really focusing on the body's response to trauma, not the traumatic event itself. So this is a modality, again, where a lot of times, especially with first responders and military, it's very difficult to come in and just start talking about trauma. And so it's really finding other methods that you can engage people without having to rehash and bring those traumatic events up very early on. Sometimes will help people to let their guard down and open them up to further treatment. Another modality we use here, we have two. There's biofeedback, neurofeedback. Just briefly, I wanted to touch on these so we can keep moving. But the biofeedback essentially is looking at things such as heart rate variability. Really, it's teaching your body how it's responding and how it can alter that, and looking at how they can relax after stress exposure. So really what you do is you do these heart rate variability. You can teach people to actually monitor and change that with different techniques, whether it's respiratory training, different modalities. And really when they see the effects they can have, it's very empowering. This is not just for trauma. We use this also for depression, anxiety, and other mood disorders as well. So it is an important modality that we do quite a bit of here. Along those same lines, of course, would be neurofeedback. Let's see if I can pull these up. Neurofeedback, of course, involves looking at, you can hook up to an EEG machine to really essentially retrain your brain. You're looking at, if you have information about what your brain is doing and you can see the brain waves in real time, you actually can use that information to change it and essentially retrain your brain, which is pretty fascinating. This is a very, very effective modality. It's very empowering for patients. You can actually transform a dysregulated brainwave pattern into a normal, healthy, organized pattern. Again, a lot of the efficacy has been shown. You can use it for ADHD, migraine, tension, headaches, insomnia, chronic pain. And again, we do use some of this for the mood disorders and some trauma work as well. Wanted to briefly touch on body work. This is an important aspect of what we do. When you come in, again, I mentioned that talking about trauma is very difficult for people, especially while you're still establishing trust with the treatment facility and the therapist. One of the modalities that you can do as somebody's stuck in that fight or flight or sometimes freeze response is to engage the body and really, as Bessel van der Kolk says, the body keeps the score. And so if you can go after the traumatic response that's stuck in the body, that hypervigilant, revved up fight or flight response, a lot of times you have to take that autonomic nervous system offline in order to actually engage in some talk therapy. And so really recalibrating the autonomic nervous system, and some ways you can do that. Of course, acupuncture is one of those modalities that we use here. A lot of this information is in the slide, so I'm not gonna go by it line by line, but we do use acupuncture both for PTSD, again, recalibrating the autonomic nervous system. We also use it a lot for alternative pain management, which is a big part of what we do here as well. So it's not unusual that we'll have a first responder or a service member or a veteran that comes in that, has suffered injuries on the job, that has chronic pain. As a lot of us know, there's a very, very strong relationship between pain and trauma. And vice versa. And so a lot of the alpha males and females that come in, the way they communicate that they're struggling emotionally is through their bodies, and so that's somatic complaints. So really having some of these modalities to go after those somatic complaints and pain issues really opens the door for them to be able to talk about maybe some of the underlying trauma and issues that are going on for them. Going to move through the acupuncture here. Acupuncture is very important. Of course, there's a lot of key points on it. I just wanted to keep us on time over here. One of the other modalities that we're incorporating more and more here at Sierra Tucson is actually, get to it, is actually yoga. The suspense is killing me here. There we go. So yoga is another modality that we're using a lot, and really going into a room and convincing a bunch of alpha men and women that they're going to do yoga sometimes can be a tough sell. I've had to do it with groups of patients before. Again, I'm probably the least flexible guy on the planet, but really kind of showing them that it's okay to engage in that, and really the benefits of it. And a lot of professional athletes and so are doing it as well. Not just about flexibility. It's really about becoming in tune with your body, really learning to reconnect with your body. The part of our brain that is responsible for integrating all the input from our internal organs is actually deeply affected by yoga, and so it's learning proprioception, getting that input from your joints and muscle movements, and really incorporating that again so that you're aware of your body. Helps with a lot of those somatic complaints and the way that we manifest trauma and depression and anxiety. So some of the other things it's helpful for, again, would be the alexithymia, which is not being able to describe your emotions. So this is another modality we use when talk therapy is maybe not going to be the first line, at least until we do some of the body work, as well as dissociation and depersonalization, because again, you have that sense of being disconnected from yourself and your body. Wanted to shift gears just to talk about resilience. You can't do a talk about trauma and first responders without talking about resilience. So this has been a very hot topic, and there's a few key points that I'd like to discuss as far as resilience goes. Really, just to define resilience, it is the dynamic process through which an individual can adaptively overcome a stressful and/or traumatic event while maintaining relatively normal physical and psychological function over time. So really, resilience, and sometimes it's often referred to as the absence of diagnosable psychiatric conditions, is not the best way of looking at it. It's more like a constructive adaptation to some of the adversity and the trauma. So, if you look at some of the research on resilience, the reason I show a bell curve and the normal distribution is if you look at a response and those people that will suffer from PTSD following a traumatic event, certain people have very limited resilience, will be on the left-hand, lower end of the bell curve. Then there's the general public, and then there's a higher percentage that have that resilience and will actually, instead of being deeply affected, or will be deeply affected, but will go on to do a concept which is called post-traumatic growth, and taking those traumatic experiences and actually learning to adapt and grow from them. So let's see if we can pull up. As far as, one of the ways I've heard resilience, if you actually look up resilience as far as its non-medical definition, it's actually, and I don't often compare human beings to buildings, but this actually resonated with me. So another way of looking at it is it's a design objective for buildings and infrastructure, the ability to absorb or avoid damage without suffering complete failure. And so I think if you explain it in those terms, it actually makes a lot of sense, right? It's helping people to handle damage and to handle and absorb those blows and trauma without, having a complete failure and really bouncing back from it. So a couple things I want to talk about is really what we're born with and how we can strengthen that. So there's a lot of research as far as the genetics of resilience, and even more so looking at kind of what we're born with, and what I mean by that is we all have our genetic makeup, and a lot of times the parts of our brains and the genes that lead to the development of those parts of our brains, like the amygdala, the thalamus, and the neurotransmitters, all of those things are subject to genetic makeup. And so some people, a lot of studies have shown, just have a different genetic makeup. So the studies looking at, what genes predispose us to being resilient versus, being vulnerable to traumatic experiences. This is a real hot topic for research right now. I think one of the big areas of research in this is looking at how do we target treatments to specific genes and lack thereof, and how can we go after those things. So there's a lot of novel treatments. Just to name a few, there's actually with norepinephrine, a lot of people studies that have shown norepinephrine response in people that are resilient. And again, this is some of the genetic makeup. People that are more sensitive to norepinephrine, of course, would be considered to be perhaps more vulnerable, and people that are more resilient would have decreased sensitivity to norepinephrine, specifically in the amygdala and some of the parts of the brain that I've mentioned. So there's another chemical, again, they've looked at in recent studies, looked at neuropeptide Y, and not to get too into the neurobiology, but this has actually been shown. They've done studies with folks that have been through the SERE training, or the Survival, Evasion, Resistance, and Escape training. They've looked at the special forces versus those in their regular infantry counterparts, found to have higher concentrations of this neuropeptide Y. So they've actually gone a few steps past that to look at, hey, maybe we can put this into a drug formulation. We could do intranasal neuropeptide Y. As of right now, a lot of these are in kind of clinical trials and recruitment phases, but I think these novel treatment mechanisms that are very specific to resilient-based factors are going to be pretty exciting research for us. Not that we're going to all carry around inhalers, but looking at how can we really capitalize on some of these molecules. Another one very similar, another molecule is called galanin, and there's a lot of research going into that right now as far as its ability to block the stress response and really counteract that fight or flight response that's happening. And then one other key point with resilience as far as genetics and what we're born with is the concept of epigenetics, which is not just a fancy way of saying genetics. It's actually, we're all born with our DNA, but how we express those genes is very subjected to our life experiences. And so if you're born with a certain DNA makeup and over time you are subjected to significant amounts of childhood abuse or neglect, you will actually express different phenotypes, or these things will manifest themselves differently based on your experiences. And so there's a lot of research looking at how those processes happen and how they manifest as adults, and the trauma response in general. So it's kind of an exciting area of research to kind of keep our eye on. There's also a lot of thoughts as far as the dopamine paths and serotonin. Of course, we know that the serotonin medications such as the SSRIs are strongly implicated. A lot of the drug development at this point for those is looking at how can we be a little bit more specific in those drugs so that we're not just blanketly blocking serotonin reuptake. We can go after specific receptor subtypes, because as we all know, there are some side effects with a lot of these medications. So we're looking at ways that we can decrease some of the effects on erectile dysfunction, which is an absolute deal breaker for 99% of the patients I work with. And really, we need to find some better molecules that will accomplish what we're looking for from the PTSD, if you will, but not have some of those side effects that are deal breakers. So it's an exciting area of research that I will continue to track, and I would encourage you to do so as well. And how can we strengthen resilience? So many of you, of course, are familiar with resilience training. It's the big push right now, and it's incorporated into pretty much all first responder and military training at this point. So one of the models I just wanted to highlight before we run out of time would be the Penn Resilience Program. Now, that was started by Dr. Seligman at Penn, and really, he's basically the father of a couple things. He identified learned helplessness in his early research, but went on to look at positive psychology and resilience. And so he built a program of strengthening resilience and really what that means. Because of his innovative ideas, the United States Army actually reached out to him and wanted to incorporate that into the resilience training for our U.S. Army. And so they've actually developed this program. It's the Master Resilience Training Program for the soldiers, also family members of soldiers, and some Department of Army civilians. Really, the Master Resilience Training is working with, it's kind of a train the trainer program, if you will. It's teaching the teachers of the Army or the drill sergeants how to both use resilience in their everyday lives as well as teach that to the soldiers that they are responsible for. So it has been rolled out. A lot of the data has been extremely positive so far as these programs are concerned, and it continues to grow. On the same lines, again, in the military and the Army, they have the Comprehensive Soldier and Family Fitness Program, which is, again, looking at strengthening resilience. Of course, we don't have time to go into quite a few of the other programs, but that's the premise for them. So looking at what this program and many like it are focusing on, just a few characteristics. The 6 core characteristics that are focused on with this, and there's a lot of subsets, if you will, but self-awareness, the ability to pay attention to your thoughts, your emotions, your behaviors, and your psychological reactions. So being aware of yourself. Along those same lines, looking at self-regulation, so the ability to change one's thoughts, emotions, behaviors, and physiology in the service of a desired outcome. And then, of course, mental agility, so really the ability to look at situations from multiple perspectives and to think creatively and flexibly. Strengths of character, the ability to use one's top strengths to engage authentically, overcome challenges, and create a life aligned with your values. Connection, so the ability to build and maintain strong, trusting relationships. Of course, this is one of the absolute keys to resilience, is surrounding yourself with positive support systems, both your immediate supports, coworkers, colleagues. Connection has been found to be probably one of the most important factors in our response to trauma. And then really optimizing optimism, if you will. So the ability to notice and expect the positive, to focus on what we can control, and to take purposeful action. So I think these are the 6 key principles, if you will, and again, this spins off into multiple different versions, but that's kind of what we can do as far as strengthening resilience. And if you put up a beautiful picture from Sierra Tucson, that is my cue to stop talking.
All right, Dr. Wilson, thank you. That was a very informative presentation. We're going to go ahead and get to some questions here. We've already had some questions coming in from our audience. However, we would like to remind you that you can use the Q&A area below the slides to submit a question at any time. And also, to download a copy of the slides, please click the Resources tab to the right of the presentation window. All right, let's dive into some questions here. All right, this question came in fairly early in the presentation. Most urine tests can test levels of medications. Given gabapentin is being abused more by clients, are there additional ways to verify whether the prescribed medication is being abused by clients?
So that's a great question. I think that's one of the things we're looking at right now is both testing for the presence of gabapentin versus, if we can get drug levels. Now, obviously, if we can get drug levels, that would be the ideal way to manage that moving forward. As with a lot of these things, it's going to come down to cost, and for every one of these more specific findings on drug screens, the cost goes up pretty exponentially. So, to my knowledge, that's the direction we're going, is looking at, how do we address this kind of growing epidemic, which has been, brewing for quite some time, but being able to track the presence of and the levels is going to be key for us. So I think that's where we're at right now.
All right. You mentioned resilience training towards the end of the presentation. It was something that's becoming a little bit more popular. Are there other trends in treatment of post-traumatic stress in service members and first responders? Anything that's kind of emerged, new trends in the last 5 years in treatment modalities that are gaining popularity?
Yeah, so one of the big pushes for a lot of these modalities, a lot of them have some similar undertones and foundation, which is whether it's a CBT or cognitive behavioral therapy based modality. Along those lines, you have CPT and certain spin-offs. Really, what people are looking more and more at is how do we trim down the length of treatment. So a lot of the different modalities coming out now are looking at brief. The key word would be like brief therapy, whether it's brief exposure, brief cognitive-based therapy modality. And I think, of course, the logic behind that is that we don't have this infinite amount of time to work, especially with first responders and the active duty service members. A lot of them are looking at how do we get this fixed sooner than later. And really, a lot of the research has been pretty supportive of some of these more brief modalities, looking at outcomes. I think one of the keys to that is if you know that you have, let's say, 6 or 8 sessions, you are maybe more inclined to actively engage in that process as opposed to kind of slowly but surely putting one foot in the water. You're more likely to say, look, I've got 6 or 8 sessions, I'm going to just dive right in and get this addressed. So I think that's the trend, is maybe towards a more brief version of some of these different modalities.
All right. How does Sierra Tucson determine which modality or treatment approach to utilize with each patient?
That's a great question. What we do is we'll have everybody come in, of course, for an intake, and we have a team of different experts, if you will, meet with them. We'll have a psychiatrist, a psychologist, oftentimes a naturopath, and have all these different people meet with them and really try to, as a team, have a collaborative approach and say, this is what I'm seeing, what are you seeing, and take all that information to really formulate a plan, which would be, let's put them in the trauma path, or let's put them in our mood path or addiction co-occurring path. Now, the caveat to that is that we don't always get that right. And so if you put somebody in a path and maybe they're not making as much progress as you'd like to see, we have the ability to, and I encourage places to really shift gears and say, this is not working, let's try something else, let's make some changes to the treatment plan and really adapt in real time. So we don't always get that right. We make a really good effort to take a stab at it initially, but then it's also being able to adapt to it as we move along.
Okay, kind of building off of that then, as you're adapting as you move along, is there any sort of a guideline that you try to follow in terms of how long you proceed down a certain path before you start adjusting your treatment approach?
Yeah, I mean, that's really, it's not necessarily a guideline. We staff these cases pretty much every day, to be honest with you. If somebody's really struggling, we have our staffing and we'll give feedback. Now, it's important, of course, if somebody has 1 session or 2 sessions of EMDR and says, oh, I don't think this is for me, I think it's, a bunch of hocus pocus or whatever they think, it's important that we address that concern. We really encourage people to give things an adequate trial and, say we've done it for maybe 3-4 sessions and we're not making headway, we need to look at maybe why we're not making headway. We need to explore other options. We can even have consults of different specialists come in to say, hey, let's walk through this. Tell me where the barriers are for you to have some breakthroughs here. So we, of course, it's kind of it's a fine line. It's a balance, if you will, but we just try to individualize that as much as we can for each patient.
All right. Next question we have from our audience: how do you address abstinence from alcohol and other non-prescribed drugs? This audience member says that it's been a struggle with PTSD or trauma patients, knowing that their impact of drug or alcohol use will negatively affect their progress.
So it's a great question. So we, of course, we encourage abstinence from drugs and alcohol, especially if you're going to be in treatment for PTSD. A lot of the research will show the negative effects and really the drug interactions with or I should say medication interactions with alcohol and illicit drugs. So we really encourage abstinence, and while they're here, we really try to get them in programming to address those things. I think, speaking to the fact that they're afraid of the repercussions, if you will, there's a lot of underreporting. And so I would say most of our folks that when they first get here, they say this is how much, and then as we work with them a little bit more information comes out and they open up about that a little bit. It's really that fear of consequences that I think is why a lot of the data is so limited for, substance abuse and really just mental health diagnoses in general. So we do encourage abstinence if at all possible. Of course, we never encourage anybody to use any illicit drugs. Alcohol, if it's used recreationally and that's not the primary thing, of course, we provide a lot of psychoeducation on some of the negative effects and the addictive potential and how you can self-medicate with it. So the other kind of interesting thing that we don't spend a lot of time working on here is nicotine cessation. If somebody comes in here with pretty significant mood symptoms and PTSD, you kind of have to pick your battles, for lack of a better term, and so I don't spend a lot of time trying to have everybody quit smoking if that's one of their, I will say, maybe unhealthy coping skills. We really try to focus on the bigger battles first. So.
Okay. Are more clinicians utilizing virtual reality-assisted prolonged exposure therapy? And in your opinion, is this an effective treatment for a service member or first responder with a goal of returning to duty?
So yes, virtual reality for exposure therapy is actually a real hot topic. There's a lot of research going on with it right now, especially given the lack of resources as far as the lack of therapists, the lack of psychiatrists, psychologists. Really looking at modalities that we can do some of these things and have a greater outreach to people. So I think we'll see more and more of that. Some of the preliminary data has been good. Along those same lines, again, we look at the huge surge in telemedicine as far as our ability to outreach and reach people in different areas of the country that historically have not been able to access those services. So virtual reality, online counseling, online therapy, and even webinar type groups. There's a lot of these technological advances that are increasing access to care, and I think the data will be shortly there behind. So I'm following that as well.
Alrighty, that's going to be all the time we have for questions for today. A lot of great questions that came in there, and try to get to as many of them as we can. We do have some final instructions regarding CE credit. Do not leave this page. Please continue to stay on the platform, and the site will automatically redirect you to a survey, and this must be completed in order to generate your CE certificate. For those watching in a group, as a reminder, please download the group submission guide in the resources tab to the right of the slides and follow the instructions provided. Please note CE credit is not available for the archived webinar. It is only available for the live event on May 9th, 2018. I want to thank Dr. Aaron Wilson once again for an excellent presentation. I'd also like to thank our sponsor, Sierra Tucson, for making today's program possible. Finally, thank you to you and our audience for participating today. We hope you'll join us in the future for another IABHC webinar. This concludes today's presentation. Have a great day.